Alright, so we're talking about gynecology. We're going to talk about reproductive endocrinology, baby. So let's start with amenorrhea. Well, primary amenorrhea is defined as the absence of menses by age 16. By age 16, if a patient with secondary characteristics or absence of secondary characteristics at age 14. Okay, that's the definition of primary amenorrhea. So secondary sexual characteristics include breast development, and pubic hair. And remember, this is by age 14. So an absence of secondary sexual characteristics indicates a lack of what? Lack of estrogen. Remember that, lack of estrogen, which is pretty much common sense. Now, here's the hard part. What causes the inadequate estrogen? All right, let's talk about that. Well, could be constitutional growth delay, which it usually is. It could be ovarian insufficiency. Could be Turner syndrome. A little web necking there. It could be central hypogonadism. Caused by malnutrition, a prolactinoma, stress, etc., etc. So patients with normal secondary sexual characteristics but no menses by age 16 have normal estrogen, indicating what? A normal hypothalamic pituitary ovarian function. So the problem's got to be elsewhere. What else could be the problem? Well, it's you got two things. Could be an anatomic abnormality, which does happen. That is like Mullerian dysgenesis, or agenesis, I'm sorry. Mullerian agenesis, such as a blind in the vagina or an imperforate hymen. And you can also have complete androgen insensitivity. Complete androgen sensitivity. These patients are genetically male but lack testosterone receptors. Okay? Genetically they are male, but they lack testosterone receptors. Testosterone is converted into estrogen, leading to what? Breast development or gynecomastia, and these patients will lack pubic hair. Okay, that's all primary amenorrhea. So now let's talk about secondary amenorrhea. Secondary amenorrhea is defined as 6 months. This is very specific, so remember this. 6 months without menses in a woman who has passed menarche. Six months. Six months without menses. That is secondary amenorrhea. So what is the first step in, not management, but evaluation? This is very important for secondary amenorrhea. What do you think it is? Pregnancy test. Do not forget that. Pregnancy test, pregnancy test, pregnancy test. Constitutional growth delay is diagnosed with an x-ray of the bones to determine the bone age. If the bone age is less than 12 years old, a diagnosis is made and no treatment is indicated. Now, the next step would be to measure hormone levels of GnRH, LH, FSH, estrogen, and progesterone. Okay? If all the hormone levels are low and at the prepubertal levels, the patient has a constitutional growth delay. So if all of these are low, it's constitutional growth delay. Okay? Now, if all hormone levels are low but are in the pubertal range, the patient has hypogonadotropic hypogonadism. So let's get a new page for that. Hypogonadotropic hypogonadism. This is a problem with what? So remember, these hormone levels are all low, GnRH, LH, FSH, estrogen, and progesterone, but they're in the pubertal range. So there's a problem with what? Could be a problem with the two things. Either number one, the hypothalamus, or the pituitary gland. Okay? Now, if GnRH and the LH-FSH are elevated, but estrogen and progesterone are low, what would that be called? That would be called a hypergonadotropic hypogonadism. So they will have elevated GnRH, LH, FSH, but decreased estrogen and progesterone. Okay. Now, this indicates a problem with what? This indicates a problem with the ovaries' production of estrogen. Okay? So it's literally that simple. It indicates a problem with the ovaries' production of estrogen. Now, if the GnRH, the LH, and the FSH, estrogen and progesterone are high, what do you suspect? So if they're all high, you suspect Polycystic Ovarian Syndrome or a problem with estrogen receptors. It's one of those two things. If all levels are high. Okay? Polycystic Ovarian Syndrome or a problem with the estrogen receptors. Now, if all hormone levels are normal, what would you suspect there? If all of them are normal, you suspect an anatomic abnormality. An anatomic abnormality. Now, evaluation for other causes of secondary amenorrhea include the following. For PCOS, what do? You check fasting blood sugars. Check fasting blood sugars. Now, also the dexamethasone suppression test. The dexamethasone suppression test distinguishes between what? It distinguishes between Cushing's, CAH, congenital adrenal hyperplasia, and Addison's disease. Okay? Now, once hormone levels are established, imaging and further workup is warranted. So what do you think best evaluates the ovaries? The best evaluation of the ovaries is the ultrasound. That is the best, always the best evaluation of the ovaries. Okay? Now, a karyotype will diagnose androgen insensitivity. So let's get us a new page to talk about this here. Androgen insensitivity. Alright, so you do a karyotype, and that diagnoses an XY karyotype, or Turner's syndrome. Do you remember what that karyotype was? XO. Very good. XO. Now, for hypogonadotropic hypogonadism, where a problem with the hypothalamus or pituitary is suspected, what would you measure or tests you would obtain? You would measure a specific hormone. That would be prolactin. So that should give you a clue as to what test you should also do. A cranial MRI. Okay? So not too bad. Now, if TSH and prolactin levels are normal, what would you start? This is how you. You start a progesterone or a progestin challenge test. Okay? Now, a progestin challenge is a 10-day course of oral progestin, which primes the uterus and should be followed by menstrual flow when the progestin is stopped. So it's called withdrawal bleeding. Now, a positive progestin challenge indicates the patient had withdrawal bleed after 10-day course. Okay? These patients have a normal uterine lining and a normal estrogen function. So the etiology of their amenorrhea, if the positive test comes back, may be anovulation, from this is important, pulsatile, non-pulsatile GnRH. Or what else? Or Polycystic Ovarian Syndrome. Very good. The next step in management after a positive progestin challenge would be what? Check, if you want to diagnose PCOS, what do you check? You check one thing. You check for high levels of LH. Okay? Now, what if the tests come back, the progestin challenge is negative? So that means after a 10-day course, the patient has no withdrawal bleeding. These patients may have a uterine abnormality or estrogen deficiency. So it's got to be one of those two things. So the next step in management after a negative, not a positive, but a negative progestin challenge is you check what? Check the FSH. Check the FSH, which is secreted by the anterior pituitary gland. Now, if you have an increased FSH, is indicative of hypergonadotropic hypogonadism, such as ovarian failure. Remember, hypergonadotropic hypogonadism, that's ovarian failure. Now, if you had a decreased FSH, let's see if you understand this, what would that tell you? What would that warrant? A cyclic, this is very important, a cyclic estrogen progesterone challenge. Should be performed if the FSH is decreased. Okay? So let's talk about a cyclic estrogen progesterone challenge. A cyclic estrogen progesterone challenge should be followed by a withdrawal bleed. So positive withdrawal bleed indicates what? The patient has hypogonadotropic hypogonadism, which can be from stress. We talked about this earlier. Maybe over-exercising, such as in the athletic female. Starting to make sense. Malnutrition, which is why it's important to eat right, etc. So that's pretty. So hypogonadotropic hypogonadism, that's when you start thinking about these things. Now, a negative withdrawal bleed with a cyclic estrogen progesterone challenge indicates a problem with the uterine lining or the anatomy. The uterine lining or the anatomy. Now, let's talk about the treatment. The treatment of primary amenorrhea should include menarche or treatment factors preventing menarche. So, for constitutional growth delay, what do you think you should do there? There's no treatment indicated there. They will grow eventually. Now, if you have an anatomic abnormality, a surgical intervention is needed. Surgery will be needed. Now, if you have hypogonadism, you need hormone replacement therapy. With low dose estrogen. Okay? Now, that was for primary amenorrhea's treatment. Let's talk about the treatment for secondary amenorrhea. The treatment for secondary amenorrhea is to address the underlying cause of the amenorrhea. So if it's hypothalamic, in etiology, what do? You replace GnRH. Now, if it's premature ovarian failure, what do there? You add estrogen and progesterone replacement. And you can have surgical removal of tumors if they are there. So that is amenorrhea in a nutshell for you. I know that's a lot, but as you can see, they can test you so many different ways there. So definitely be acquainted and know this stuff well. Okay, so now on to CAH, congenital adrenal hyperplasia. Congenital adrenal hyperplasia, or adrenogenital syndrome, is an autosomal recessive disorder caused by deficiencies in adrenal steroid synthesis enzymes. The three main enzymatic deficiencies are, you should be able to tell me this, number one, and most common, 21 hydroxylase, number two, 11 hydroxylase, and number three, what would that be? 17 hydroxylase deficiencies. Now, because of the overall lack of adrenal steroid synthesis, there is a lack of end product negative feedback, which causes high levels of what? ACTH. Very good. High levels of ACTH, which leads to what? Adrenal hyperplasia. That's simple. Now, like I said, the most common is the 21-OH deficiency. This enzyme is responsible for the synthesis of what two things? So the 21 hydroxylase is responsible for the synthesis of aldosterone and cortisol. Those two things. Deficiency leads to a decreased aldosterone, a decreased cortisol, but a increase in what? Androgens. So the aldosterone is down, the cortisol is down, but the androgens are increased. Clinically, this presents as a salt wasting with hypotension and ambiguous female genitalia, or it could present how in a male with precocious puberty called McCune-Albright syndrome. Very, very good. So you're starting to get it. So the treatment of congenital adrenal hyperplasia, what do you think that would be? The treatment would be glucocorticoid therapy. Great example of this is prednisone, and surgical correction of ambiguous genitalia may be required as well. And literally, that is congenital adrenal hyperplasia. It's no more complicated than that. So let's talk about Cushing's syndrome. The hallmark of Cushing's is high cortisol levels. High cortisol levels as measured by an increased 24-hour urine-free cortisol level. Now recall cortisol's functions. It's an anti-inflammatory, it maintains the blood pressure, it increases gluconeogenesis, lipolysis, proteolysis mainly to turn into sugars by what amino acid? That's right, alanine. It decreases immune function, and it also decreases what else? Bone formation. So, you know, that's the problem with putting people on prednisone is the decreased immune function. You know, you're going to get certain infections. So signs and symptoms, buffalo hump, weight gain, moon faces. Are they going to be hyper or hypotensive? Hypertensive. Very good. They're going to be hyperglycemic as well. They're going to have osteoporosis. They're going to have, clue here, amenorrhea. Amenorrhea. They're going to be impotent. So that's known as anorgasmia. And they're going to have striae. So the causes of Cushing's include, number one, Cushing's disease. Cushing's disease, which is an ACTH secreting pituitary adenoma. With resultant increase in cortisol levels. Now, only the primary pituitary adenoma is referred to as Cushing's disease. The other etiologies collectively reflect a Cushing syndrome. So the dexamethasone suppression test may be used to distinguish between Cushing's disease and Cushing's syndrome. Now, if you have, let me ask you this, if you have ectopic ACTH production, think about this. What does that indicate? Small cell carcinoma of the lung, very good, with increased or decreased ACTH. Increased ACTH, good. Now, an iatrogenic cause is a patient taking cortisol for therapy. So they're going to have a decreased ACTH due to the negative feedback to the pituitary gland, right? Very simple. Now, if they have adrenal hyperplasia or a neoplasm, the ACTH will be down due to the negative feedback to the pituitary gland. So that's what, it's literally that simple. So the only time the ACTH is up is if you have atopic ACTH production and classically small cell lung cancer or carcinoma. Now the etiology of Cushing's syndrome can be elucidated by using the dexamethasone suppression test. No surprise there. Dexamethasone is a high-potency corticosteroid that interacts with the body's normal feedback system to aid in the diagnosis of Cushing's. Now, in a normal individual, low dose, listen to me very carefully, low dose dexamethasone will suppress ACTH and thus it'll suppress cortisol levels. Now, in a patient with pituitary Cushing's, low-dose dexamethasone will fail to suppress the ACTH and cortisol, but a high-dose dexamethasone will suppress the body's endogenous ACTH production, therefore cortisol as well, by negative feedback. But what about the patient with the ectopic ACTH production? If you have ectopic, what will the dexamethasone suppression test do to this? It will not suppress ACTH and therefore not suppress cortisol levels because only pituitary ACTH is susceptible to feedback inhibition. Thus, this patient will have elevated cortisol after a high-dose dexamethasone suppression test. So if they have elevated cortisol after you give them high dose, you need to worry because they got some type of cancer or tumor going on. Now, the treatment options are dependent on the cause specifically. So the treatment for this would be tumor excision, with post-op glucocorticosteroid replacement. You can also do drug therapy. A drug that you might not be aware of is called mitotane. Mitotane. And what that is it's an anti-neoplastic agent. Anti-neoplastic agent, it selectively inhibits the adrenal cortex. Okay? Now, another drug therapy is ketoconazole. I know you're saying, what? That's a fungal thing, right? Yes, it is. But why would I use ketoconazole here, which is an antifungal? It also inhibits steroid synthesis. Therefore, and it also inhibits the P450 system. Okay? So that is everything you need to know about Cushing's. It's just pay very close attention to the details you're asked and you'll be fine with it. It's not that bad. So let's talk about hyperprolactinemia. Notice I said anemia. Okay, so we're talking about high prolactin in the blood. And as you can see in the picture here, you have an elevated optic nerve right there because of a prolactinoma pushing up. So what type of visual effects could you have here? Bilateral hemianopsia, that's right. Okay, so the treatment for a prolactinoma, The treatment for a prolactinoma includes, number one, bromocriptine, or carbolene, carbagoline. Those are both dopamine what? Agonist. Dopamine agonist. Dopamine inhibits prolactin release. This is a high yield point. This is also why dopamine antagonists, for example, antipsychotics, cause galactorrhea. Now, low dopamine leads to high prolactin, as you might expect. So now there's also a thing for a large tumor. For a large tumor, you do a transsphygmodal surgical resection. So transsphenoidal surgical resection for large tumors. So what are the signs and symptoms? Impotence, amenorrhea, surprisingly not, gynecomastia, galactorrhea, and a headache. You got a tumor in your head, man. So enlargement of the pituitary gland compresses what? Compresses the optic chiasm right here. Now, if you compress the optic chiasm, like I said earlier, you will get a bilateral hemianopsia. So what's that mean? That means you lose what? Lose peripheral vision. You got tunnel vision. Peripheral vision. Now, you also can have a mass effect on the surrounding pituitary gland, causing general hypopituitary symptoms. Now, a prolactinoma is a benign tumor of the anterior pituitary that secretes the hormone prolactin from the anterior pituitary. Recall to remember, the hormones like ACTH, FSH, TSH, all that stuff, growth hormone. Anterior pituitary releases those. The only two that are released by the posterior pituitary gland is what? ADH and oxytocin. Very good. And that is pretty much a prolactinoma or hyperprolactinemia. So let's talk about your thyroid gland. So the lab evaluation will reveal the following values. We start with a serum TSH. If you have primary hypothyroidism caused by like a thyroid hypofunction, you will have an increased TSH, right? If you have a secondary hypothyroidism, that's caused by pituitary hypofunction. So what will your TSH be like? Decreased TSH. Very good. What about if you had a tertiary hypothyroidism? What is that caused by? Hypothalamic hypofunction, so you're going to also have a decreased TSH. Very good. Now, when hypothyroidism is clinically suspected, serum TSH is usually the most sensitive test. You're going to have a decreased total T4 and free T4. Okay? Now, what about the resin uptake test with the T3? Will it be increased or decreased? Hard question. It'll be decreased. Decreased T3 resin uptake. That is crazy important to remember because they ask you about this all the time because so many students miss it and just don't understand it. But just know that it's decreased when hypothyroidism is there, okay? Because what does resin bind? It binds free T3. Now, the signs and symptoms can be organized by systems, so that's how we're going to talk about it. The metabolic problems of hypothyroidism, because the thyroid controls everything. I'm not going to write them all in here, so just listen. You'll have a decreased basal metabolic rate, so that is going to have the decreased oxygen consumption, which is going to lead to a decreased respiratory rate. You're going to be, do you think you will gain weight or lose weight? You're going to gain weight, right? So is that anabolic or catabolic? That means you're anabolic. So tell me about the nitrogen balance in your body. It's going to be positive. What about your heat production? Your heat production will be down. Remember, we're still talking about metabolism here. So you're going to see decreased sweating and cold intolerance, and you're going to have growth retardation. Let's go to the heart. Now, peripheral vasoconstriction to maintain body heat leads to cool, pale, and dry skin. So you're going to have decreased synthesis of cardiac beta-1 receptors, right? Which leads to a decreased heart rate. So you're going to have bradycardia. You're going to have a decreased contractility, which if you have a decreased contractility, that leads to a decreased stroke volume. So your pulse pressure would look like what if your stroke volume is down? It's going to be decreased. Your heart rate and your stroke volume both being down cause a decreased cardiac output. So you have a decreased exercise capacity. Maybe they're going to complain of shortness of breath, etc. On the EKG, they're going to have blunted EKG voltages. They're going to have accelerated atherogenesis. So they're going to have what's their total cholesterol and LDL going to look like? They're going to have an increased total cholesterol and an increased LDL. Let's go to the central nervous system. They're going to have slow, deep tendon reflexes with prolonged relaxation phase. That's a good buzzword for you. All right, so they're going to be fatigued. They're going to be lethargic. They're going to be mentally slow. They could be mentally retarded. Dermatologically, they're going to have coarse, brittle hair and nails, yellow, orange skin. They could have myxedema, which is non-pitting edema. I'm going to say it again. They could have myxedema, which is non-pitting edema. Non-pitting edema due to interstitial accumulation of osmotically active mucopolysaccharides is why this happens. Of the hands, the face, the periorbital region. What about the gastrointestinal system? You think their GI motility will be up or be down? It'll be down. So will they be constipated or have diarrhea? They will be constipated. Musculoskeletally, they could have carpal tunnel syndrome. Endocrine system, they're going to have a hyperprolactinemia if primary or secondary hypothyroidism. So they're going to have a decreased T3, T4, an increased TRH, and an increased prolactin, leading to what? You got it. Amenorrhea. Very good. And remember, that was a decreased T3, T4, which leads to an increase in TRH, which leads to an increase in prolactin. See, not so bad. Now, the etiologies of hypothyroidism. For primary hypothyroidism, you can have Hashimoto's thyroiditis, which is a chronic autoimmune thyroiditis. You can have post-ablation, which is surgical, or iodine-131 radiation. You can have an iodine deficiency. Now, what drugs would cause primary hypothyroidism that you can think of? There's three that I want you to know. And those three drugs are, number one, lithium. Number two, amiodarone. And number 3, sulfonamides. Okay. You can also have painless subacute lymphocytic thyroiditis. But what about secondary hypothyroidism? That's caused by what? Secondary, like we said earlier, is caused by the pituitary hypofunction. Okay. Now, tertiary hypothyroidism is caused by a hypothalamic hypofunction. All right. Now, across the world, there's an endemic dietary iodine deficiency, and that is the most common cause of hypothyroidism worldwide. So you need to know that. Most common cause of hypothyroidism worldwide. An iodine deficiency. Now, what is cretinism? This is children with mental retardation, pot-bellied stomach, protruding umbilicus, and a protuberant tongue. Their faces are pale and puffy. So, does that make sense why we test all newborns for hypothyroidism? What test you think we use to do that? TSH test, very good. That is the standard care because mental retardation can be minimized when a thyroid hormone is administered in a neonatal period. And why would that be? Because the thyroid, remember, acts like a fat-soluble substance. It can cross the placenta. So he still has some of mom's thyroid, okay? So to avoid, now if the mom's hypothyroid, you need to know that because the child is going to be hypothyroid too because he's dependent on the mother. Now, congenital hypothyroidism is most commonly caused by thyroid dysgenesis, okay? Congenital. Congenital hypothyroidism is most commonly caused by thyroid dysgenesis due to thyroid aplasia, hypoplasia, stuff like that. Now that may present with a hoarse cry, a weak cough, slow respiratory effort, abdominal distension, pot belly with umbilical hernia, etc., like a prolonged neonatal physiologic jaundice. So you might need to be thinking about this hypothyroidism when you see a prolonged neonatal physiologic jaundice. They're also going to have poor feeding, the neonatal hypotonia. They're going to have a macroglossia, which is a protruding tongue. Okay? You also see retarded bone age, delayed dentition, enlarged fontanelles, coarse facial features, wide set eyes, broad flat nose, dry skin, a pale body, cold extremities, etc. Now, the most serious, now listen to me, the most serious complication of hypothyroidism is what? A myxedema coma. That is the most serious complication, which generally occurs in patients with long-standing untreated hypothyroidism. This is the only emergent hypothyroid condition. It can be spontaneous onsetted or precipitated by cold exposure, infections, drugs, hypoxia. A great drug that would do this is a CNS depressant because you're already depressed. You're hypothyroid, right? So the signs and symptoms would be a hypothermic stupor, which is a coma, or hypoventilation with CO2 retention. And you think they'll have hypotension or hypertension? Hypotension. So how do you treat that? You treat it with respiratory support, intravenous levothyroxine, and one more thing, cortisol. The treatment, respiratory support, IV levothyroxine, a T4, and cortisol. That is hypothyroidism. thyroid for you in a nutshell. So I know that was a lot, but let's talk about menopause, the dreaded thing by many women. Now, with menopause, you can have premature ovarian failure. Premature ovarian failure is the loss of function of the ovaries before age what? Before age 40. You lose the function of the ovaries. A commonly cited triad for the diagnosis is amenorrhea, if you can't tell yet, amenorrhea tells you nothing there, because you got to go digging when somebody has amenorrhea. Hypergonadotropism, which is hypergonadotropism is just high levels of FSH. And hypoestrogenism. Okay? And now menopause is the cessation of what? Estrogen production, with an age-linked decline in the number of ovarian follicles. The average age of menopause in the Western world is 51 years old. That's the average, okay? Now, who do you think it's earlier in? It's earlier in smokers. That's important to know. One good reason not to smoke right there. The typical range now is from 45 to 55 years old. That's your range. Now, the hormonal changes are going to include this: a very, very high FSH. Remember that if you don't remember nothing else. You're going to have what do you think the LH will be like? It'll be elevated, but not as high as the FSH. What about the GnRH? It'll be elevated. What about the estrogen? It's going to be decreased. It's menopause, man. So symptoms of menopause include, as we know, hot flashes, vaginal atrophy, osteoporosis is a big one. Now, because she's losing estrogen, coronary artery disease, the #1 killer in America, she's also susceptible to. What do you think her libido will be like? She'll be decreased. You think she's going to be able to sleep? No. She's having hot flashes. She's also going to have insomnia. So that is what menopause is all about right there. That's basically all you need to know about it. So let's talk about polycystic ovarian syndrome, and we will be done with reproductive endocrinology. You diagnose PCOS with labs, and you do it with the LH FSH ratio greater than 2 to 1. And you also do an ultrasound. Okay? The ultrasound will show a pearl necklace sign, so that's a buzzword. If you ever hear that, think PCOS. Pearl necklace sign, which are a series of small subscapular follicular cysts. You treat this with two things. Let's write that in there. You treat it with oral contraceptives and metformin. Now, polycystic ovarian syndrome, also another way of saying this is Stein-Leventhal syndrome. Just a little something you got to know. Stein-Leventhal syndrome is one of the most common disorders of reproductive endocrinology. You better know about polycystic ovarian syndrome. Now, the classic presentation is an overweight young woman. An overweight young woman that presents with oligomenorrhea, hirsutism, virilism, infertility, and insulin resistance. The insulin resistance is seen in about 50 to 70% of women with polycystic ovarian syndrome. So it's not definitive, but it is pretty, it's pretty good. Now, the LH-FSH ratio greater than 2 to 1 also needs to have high testosterone and high estrogen. Because if your testosterone is up, your estrogen is going to be up, right? 5-alpha reductase aromatizes it. So the pathogenesis of polycystic ovarian syndrome, to be honest, is very poorly understood. It is thought now. So you're not going to be tested about things that are thought on the boards, but you need to know it still. It is thought that high amplitude GnRH pulses, let me write this in here. High amplitude GnRH pulses leads to an increased pituitary LH, which leads to an increase in ovarian androgen synthesis, which leads to an increased androgen aromatization to estrogens in what? Adipose tissue. In adipose tissue. Now, PCOS is also related to insulin resistance, as we spoke about earlier. In patients with polycystic ovarian syndrome, the ovaries are hypersensitive to insulin. Hypersensitive ovaries to insulin. Okay? Insulin stimulates the ovarian theca cells to secrete what? Androgens, while inhibiting hepatic sex hormone binding globulins. The result is an increase in free androgens. So you're going to have a decreased FSH. That is important to know. You're going to have a decreased FSH, so you're going to get follicular degeneration with a fluid-filled cyst formation. Hence, that's why they say polycystic. Starting to make sense? You're going to have, what are your androgens going to be like? They're going to be increased. Increased androgens is going to lead to hirsutism, which is going to lead to an increase in hair. And what is your estrogen going to be like? It's going to be up. Now, that means you have an increased risk of endometrial and breast cancer because of the prolonged nature of the stimulation. So that is polycystic ovarian syndrome. And that is reproductive endocrinology in a nutshell for you. I know it's a lot, but watch it a few times to get it down, and you'll never forget it.